faithfully delivering value and interpreting great books from around the world. Hello, this is Sally's Book Talk. Today, the book we're interpreting for you is The Story of the ICU. The ICU, as we often call it, is the intensive care unit. People sent there are often critically ill, hanging by a thread. You could say the ICU is a battlefield between life and death. Since its start in Denmark in 1952, the ICU has saved about 500 million lives. Today's book will take you into the ICU, into stories of rescues on the edge of life and death. The author of this book is Matt Morgan, a chief physician in the intensive care department at the University Hospital of Wales. He's worked in major hospitals across the UK and Oceania, and the book has 9 chapters. And then there are real people who may not admit that each chapter focuses on the story of an ICU patient. Through these stories, the author shows us the daily life in the ICU, with its advanced diagnostic tools and methods, and the tough decisions doctors make in a race against time. Note that the English title of this book isn't The Story of the ICU, but Critical. That name is clever because critical has multiple meanings in English. It can mean a serious medical condition or something important and key. And the ICU is an important and critical part of modern hospitals dedicated to treating critically ill patients. Sue Black, a renowned British forensic anthropologist, commented that this book is full of humility and insight. It not only lets us marvel at this medical world saving lives daily, but also reminds us how fragile life is. Next, we'll explore the daily operations of the ICU from 4 aspects. First, we'll learn what kind of place the ICU is. Second, the work protocols of ICU medical staff. Third, we'll discuss ethical issues closely tied to saving lives. Fourth, we'll follow Dr. Morgan to reflect on how to face death. In part 1, we'll learn what kind of place the ICU is. The story of the ICU begins in Denmark in 1952. That summer, an outbreak of polio hit Copenhagen, the capital of Denmark. Polio is an acute infectious disease caused by the poliovirus, commonly known as infantile paralysis. The virus often invades the central nervous system, damaging the spinal cord and causing flaccid paralysis in the limbs. Today, humans have controlled this disease through vaccination. But more than half a century ago, polio was still a terrifying epidemic disease. In that outbreak in Copenhagen, a 12-year-old girl named Wei Wei unfortunately contracted the poliovirus. The virus developed rapidly in her body. By the time she was sent to the hospital, she was in deep exhaustion and struggling to breathe. And to sustain Wei Wei's breathing, a 36-year-old doctor named Bjørn Ibsen decided to take a risk and perform an emergency tracheotomy on her. He connected Wei Wei's trachea to an inflatable bag, then squeezed the bag to use positive pressure to send air into her lungs. With each breath, Wei Wei's chest rose and fell. By the 10th breath, her heavy eyes finally opened. Next, Dr. Ibsen set up a safe and hygienic temporary ward for Wei Wei and gathered a group of medical students to continuously squeeze the bag for her every day. Over the next 6 months, more than 1,500 volunteers from the medical school came here. It wasn't until January of the following year that this manual relay work was replaced by a specialized medical ventilator, and Wei Wei survived.
And the ward where she stayed thus became the world's first intensive care unit.
Starting from this ward, intensive care units gradually became an essential part of modern hospitals. It concentrates critically ill patients, providing the best guarantees in manpower, resources, and technology to achieve good treatment outcomes. So-called critically ill patients are those with unstable vital signs, rapidly changing conditions, and failure of one or more vital organs. Ideally, ICU beds should account for about 10% of the hospital's total beds and must be close to the operating room and emergency department. Because most ICU patients come from these 2 places. In the ICU, each individual bed area must be specially equipped with ventilators to maintain vital signs, various infusion pumps, dialysis machines, and monitoring equipment. Well, facing patients struggling for survival, the ICU also has a professional team, typically including one-on-one nursing and therapy assistants, and a medical team composed of general practitioners and specialists. So, several nurses, a pharmacist, a physical therapist, a nutritionist, an occupational therapist, a social worker, a psychologist, and a range of supportive services. Among these, ICU doctors require an incredibly broad skill set. They must perform resuscitation, conduct surgeries, and assist in acquiring and interpreting medical imaging of various body parts. They use potent medications to regulate the body's physiological functions. According to Dr. Morgan, they need a deep understanding of 13,000 disease diagnoses, 6,000 medications, and 4,000 surgical procedures. Nurses are also one of the most vital components of this team. We can classify patients into 5 levels, from 0 to 4, based on the severity of their illness and the level of care they require. Level 0 patients have mild illnesses and can be treated in general wards. Level 1 patients are at risk of deterioration and are typically sent to acute wards with more frequent nursing interventions, where one nurse cares for 7 to 12 patients. Level 2 patients require high dependency care, usually with one nurse for every 2 patients. Level 3 patients are more critically ill, needing trained nurses guarding their wards 24 hours a day. Often located near or even inside the ICU, Level 4 care patients are always treated in the ICU, requiring extensive complex equipment to maintain vital signs and multiple nurses for care. This medical team relies on the most advanced instruments, medications, and treatment methods in human medicine today. For instance, if a patient experiences cardiopulmonary failure, ICU doctors use a technique called extracorporeal membrane oxygenation, also known as ECMO. During the 2021 COVID-19 outbreak, ECMO became a lifesaver for many critically ill COVID-19 patients. Simply put, ECMO is a heart-lung machine. You can think of it as a fusion of an artificial lung and an artificial heart. In principle, a heart-lung machine is simple. It draws blood from the venous system, infuses oxygen into it, then uses pressure to return it to the vessels. However, this process is extremely complex in practice. Blood clots easily, so doctors must use anticoagulants, but thinning the blood risks damaging fragile red blood cells. Since its first use in 1951, humans have continuously refined and improved this technology. It wasn't until ECMO emerged that heart-lung bypass became both convenient and safe. This device uses a gentle centrifugal pump and an ultra-thin membrane with a large surface area to oxygenate blood while protecting red blood cells. ECMO is also convenient. Simply inserting 2 catheters into subcutaneous vessels can replace cardiopulmonary function. Life-saving tools like ECMO are the hardware foundation for maintaining patients' vital signs in the ICU. In modern ICUs, medical staff can inject oxygen directly into failing hearts, insert needles as thin as 1 millimeter into blood vessels, organs, even brains, and keep patients without lung function alive for over a month. The first ICU was born in Denmark in 1952, and since then, ICUs have gradually become a crucial part of modern hospitals. But it concentrates critically ill patients, providing optimal human, material, and technical support to ensure effective treatment. Since patients are often on the brink of life and death, medical staff must make accurate judgments and take appropriate actions in minimal time. Under such immense pressure, what qualities do medical staff need besides medical skills and experience? What are the working principles in the ICU? In the next part, Part 2, we'll address this question. Besides medical skills and experience, courage and decisiveness are indispensable for medical staff. Dr. Morgan shares a story in his book about a successful rescue by his colleague, Dr. Holmes. A young woman named Melody was admitted to the ICU due to severe pneumonia. After 2 stable days, Melody's heart suddenly stopped. It appeared to be a pulmonary embolism, but since she was undergoing CPR, doctors couldn't move her to a CT scanner. Reading. Reading.
Rash treatment could cause severe bleeding throughout her body.
At this critical moment, Dr. Holmes grabbed an ultrasound scanner from the ICU corner to examine Melody's heart. Indeed, the patient's enlarged right ventricle confirmed a pulmonary embolism. Dr. Holmes then injected a powerful anticoagulant into the patient. This medication could dissolve clots anywhere in her body, while the treatment team continued CPR on Melody. 20 minutes later, Melody's heartbeat returned. Dr. Holmes achieved a perfect balance of rationality and courage, an essential quality for any ICU physician. However, even the most brilliant doctors are ordinary people. Being human, they can make mistakes.
Especially in the ICU, doctors race against time and make decisions amid complex situations and massive data, making errors even more likely.
And a small mistake could end a patient's life. Every time Dr. Morgan participates in a rescue, he takes deep breaths to calm his inner panic, trying to bring some calm and order to the chaos. But he also knows that deep breathing alone isn't enough. Fortunately, he has a set of diagnostic protocols to rely on. Today, the protocols practiced in the ICU consist of 3 aspects, all converging to avoid or reduce individual errors. The first aspect is using checklists. Research shows that no matter how detailed the professional division of labor and training, people still overlook key steps in actual work, committing errors that seem unbelievable in hindsight. Using checklists and executing their steps builds a cognitive safety net for the brain, compensating for inherent human cognitive flaws. In the ICU, each patient undergoes an average of 178 nursing operations every 24 hours, and nearly every one carries risks. Performing a few simple key checklist steps before these operations, like verifying the patient's name and allergies, can save millions of lives. The second aspect is adopting crew resource management (CRM) from the aviation industry. CRM's core mobilizes each team member's initiative and enhances coordination to maximize safety and efficiency. It empowers lower-level members in a team to question higher-ups. For example, during a flight attendant can question the captain if they believe the captain's actions threaten safety. The principle of this management model, uses multiple judgments to hedge against or offset individual errors. Today's ICU also adopts this model, where even a nurse or nutritionist can question the chief physician's actions. The third aspect is vigilance against fast thinking, inspired by Nobel laureate Daniel Kahneman's book, Thinking, Fast and Slow. Kahneman points out in this book that fast thinking, commonly used by humans, allows people to react quickly to situations, but it can easily lead people to make wrong choices, while slow thinking mobilizes attention to analyze and solve problems, making relatively correct decisions. Medical errors are often the product of fast thinking. To avoid this, medical staff must force themselves into slow thinking and remain vigilant about intuition-based judgments. For instance, a patient was transferred to the ICU from the trauma ward. A trauma department colleague told Dr. Morgan that this car accident victim had severe infection causing breathing difficulties. Dr. Morgan's instinct was to trust this diagnosis, but he constantly reminded himself not to be dominated by intuition and emotion. He needed to approach problems with slow thinking and critical reasoning. Perhaps the breathing difficulty wasn't from infection, but uncontrolled internal bleeding. If so, antibiotics and ventilators would be useless. The patient needed surgical hemostasis, and this critical thinking subtly echoes the third meaning of the book's English title. All right, let's summarize part 2. ICU work is time critical. To prevent errors under pressure, protocols address individual mistakes from multiple angles, avoiding catastrophic failures. Of course, it's still imperfect with room for improvement. In Dr. Morgan's ICU, patient numbers fluctuate predictably throughout the year. When autumn frost appears, he treats flu patients. 6 months later, he handles drowning cases from swimming accidents. These stories repeat in cycles. Dr. Morgan and colleagues often solve one problem only to immediately confront the next at full capacity. Beyond medical challenges, their work involves serious ethical considerations. In part 3, we'll explore two ethical dilemmas Dr. Morgan frequently faces. The first ethical question is whether to save guilty individuals. For example, should we save unrepentant addicts, rapists shot by police, or rapists severely injured by victims fighting back? Many may feel simple justice dictates that those who cause their own life-threatening conditions deserve their fate. Moreover, medical resources in the ICU are extremely costly. Why waste these resources on the guilty? However, Dr. Morgan believes they should and must be saved because first, those people may not actually be guilty. For example, Dr. Morgan once treated a woman admitted after a car accident. He heard she was an alcoholic whose drunk driving caused the crash, killing her 3 grandchildren in the car. Dr. Morgan felt furious, believing this woman's selfishness caused 3 young lives to vanish needlessly. When he discovered she'd had a heart transplant, he grew more resentful, feeling those medical resources were wasted. The woman ultimately died from her severe injuries. Weeks later, while organizing the deceased records, Dr. Morgan found she wasn't drunk driving. She'd had a sudden heart attack while driving because she couldn't afford anti-rejection meds post-transplant. Oh, oh, I... um, People often thoughtlessly assign moral failings and bad habits to others. They pin them on the poor, who may be innocent. Even if patients are truly heinous, doctors must still save their lives. Because doctors aren't judges. Their duty is to heal the sick and save the dying. Medical resource allocation should consider factors affecting success rates, not value judgments about patients' life choices. Well, in his book, he admits treating pedophiles, drug dealers, murderers, and rapists, not to mention alcoholics and smokers. And he further asks readers, if society denies treatment to chain smokers or alcoholics today, might it tomorrow deny the obese, introverts, motorcyclists, or extreme sports enthusiasts?
And after that, who would be next?
All right, should we save the guilty? That concludes this issue. Dr. Morgan's stance on it is unequivocal and firm. A doctor's duty is to save lives, regardless of who they are. But for another critical ethical issue, Morgan offers no simple answer. That question is, when to stop resuscitation? Stopping resuscitation and withdrawing treatment in the ICU essentially sentences the patient to death. Logically, medical staff shouldn't cease treatment until all hope is lost. But reality is far more complex. For instance, patients with severe brain injuries who have almost no chance of effective recovery. Keeping them on ventilators may prolong life but only prolong suffering. In such cases, continuing treatment may not serve the patient's best interests. So when should we stop resuscitation? In principle, this depends on the patient's own wishes. All medical procedures, from drawing blood to withdrawing or installing life support, require the patient's consent in principle. But this consent must meet 3 prerequisites. First, the patient must understand why medical staff are performing the procedure and be aware of its risks. Second, the patient must be able to independently consider and weigh these risks. Finally, the patient must be able to communicate their decision to the doctor. What is it? If the patient gives valid consent after being fully informed, doctors will honor their wishes. If they choose to forego treatment, doctors must comply. Even in extreme cases, like a Jehovah's Witness refusing blood transfusions due to religious doctrine. In such situations, even if refusal means death, doctors must respect the decision. But the problem is, most ICU patients are extremely weak or comatose, unable to make clear, independent decisions. In these cases, medical staff typically defer to the patient's immediate family. Dr. Morgan clarifies this isn't because relatives are decision makers, but because they know the patient best and can infer their likely choices. Dr. Morgan once treated Joe, a boxer who collapsed after repeated head blows during a match, later developing dangerous brain swelling in the ICU. To reduce the brain swelling, intervention was necessary. The simplest solution was a decompressive craniectomy, freeing the brain from the skull's confinement. However, this surgery risked severe complications like skull defect syndrome, prolonged coma, or permanent vegetative state. Dr. Morgan consulted Joe's parents, who immediately stated their son would accept severe disability risk if it meant survival. So, Dr. Morgan performed the decompressive craniectomy on Joe, who survived the surgery but later developed sepsis and multi-organ failure.
2 weeks later, medical staff faced another critical decision: whether to perform a tracheotomy on Joe.
Without the tracheotomy, he couldn't survive independently. But with it, he might need lifelong assistance for bathing, moving, eating, and using the toilet. Could a 19-year-old accept such a life?
This time, Dr. Morgan spent hours talking with Joe's parents, explaining they must decide not for themselves, but from Joe's perspective.
Joe's parents told the doctor he'd always been a fighter. That's why he became a boxer.
Therefore, facing death, he'd surely cling to any hope of survival as always. So, doctors performed the tracheotomy.
Joe remained comatose in the ICU for 6 weeks before finally waking and being discharged. A year and a half later, Joe could speak clearly and regained strength in his left side. Joe's story, headed to study computer science, had a happy ending, but this was one lucky case. Many decline risky treatments, while others endure unbearable suffering before ultimately passing. And choosing between mere survival and quality of life is agonizingly difficult. Regardless, if patients or families don't give up, ICU teams will exhaust all efforts to save lives. Today, 30 million patients enter ICUs globally each year, with 24 million surviving. Yet the flip side, even now, 1/5 of ICU patients die, but they're not forgotten. They reshape our understanding of death and illuminate life's meaning. Finally, in part 4, we'll explore an inevitable yet vital component of the ICU. As an ICU doctor, pronouncing death is Morgan's routine duty, performed with a specific ritual when confirming a patient's passing. He speaks to the person lying on the hospital bed, a basic sign of respect, even if they've passed away. First, he greets them and introduces himself. Then he says, "I'm going to check your pulse now," placing index and middle fingers on the neck to feel for the carotid artery's distinctive throb. Simultaneously, he places a stethoscope on their chest, listening for first and second heart sounds, followed by a long, silent 5-minute wait. After that, he lifts their eyelids.
He turns on a pen light, shining it into the dark pupils to confirm no light reflex remains.
Finally, murmuring apologies, he presses firmly on the supraorbital notch above their eyes. This painful stimulus would be unbearable for any living person, but elicits no response from the deceased. After pronouncing death, the doctor faces an even harder task: informing the family. First, he introduces himself, then says, "I'm sorry, this will be difficult. I'm afraid I don't have good news." When delivering the news, he avoids vague platitudes, like, "Your son has gone to a better place," because desperate families might press further. "Where did he go?" He states directly, "I'm so sorry, he has passed away." Reactions vary: weeping, screaming, even laughter. Some thank doctors politely. Others beg for denial. Some pound walls or hit themselves. To Dr. Morgan, these responses aren't right or wrong. They're part of human grief, proof and price of love. A heart must first have loved to be capable of breaking. After reviewing the deceased treatment, Dr. Morgan does 3 more things. He says intensive care isn't just fancy gadgets or dramatic rescues. It's not even solely about medicine. It includes pouring tea for grieving families, reminiscing about the deceased, and acknowledging life's preciousness. The first of these 3 acts is alleviating families' guilt. Many bereaved relatives blame themselves, believing their loved one might have lived if they'd acted differently. Some families who performed CPR during cardiac arrest often doubt if they did it wrong. Dr. Morgan tells them, "We wouldn't be meeting here if not for your timely action and care. Remember, you did everything right." Next, Dr. Morgan asks the family, Is there anything else you need me to answer? He gives them at least 3 opportunities to ask questions. Though families often can't formulate questions, he finally points to an empty chair. If he were sitting here listening, what would he say? This seemingly cruel question often releases the family's overwhelming grief. Some smile and say, "My dad loved jokes. He'd probably tell one."
Others answer through tears. He'd say, "Stop saving me, let me go."
Why does Dr. Morgan have families imagine the deceased response? This stems from personal experience. A bereaved parent once shared how friends and coworkers avoided him after his son's death. Most dodged him on streets. Some turned away on escalators. Not malice, just avoiding death's discomfort. When hearing of the loss, people often default to, "Sorry for your loss," then fall silent. That we love talking about loved ones, why stop when they die? So, Dr. Morgan discusses the deceased with their families. He urges us to do the same. When a friend loses their mother, beyond "I'm sorry," ask, "What was her name? What was she like? Her smile? Her passions?" The best mourning celebrates life. With this, we conclude the main content of the story of the ICU. Writing was a brief interlude in Dr. Morgan's busy career. Most time is spent saving lives in the ICU, but after COVID-19 erupted in 2020, he reconnected with readers through writing again. He published a letter from the ICU in the British Medical Journal. In the letter, Dr. Morgan wrote, "When all medical options fail, we'll stand with you and your family, speak honestly, and hold your hand. We'll remain here, shift our treatment goals, and crucially, never stop caring." We haven't forgotten the story of the ICU. That concludes our interpretation. Find reading notes below the audio. Until next time.